Okay,
Yeah.
so yeah. Shall I go ahead with the presentation?
Yes,
Yes, ma'am,
Dr.
you
Charu.
can.
Yeah.
Okay, so very good afternoon to everybody. My special thanks to Dr. Sumani for giving Megenome an opportunity to be part of this extensive oncological update webinar. So I have been allotted a very interesting topic, which is NGS in hematological malignancies. Is it parallel to solid tumors? So a pretty interesting question. Definitely, I mean, I will just take you through the insights of NGS in hematological malignancies per se, and we can have a discussion little bit around how much it is getting parallel to the NGS, which is nowadays used in solid tumors as well. The agenda will be what are the genomic technologies being used in hematological malignancies. I will be focusing on AML being the most heterogeneous disease and having the most number of mutations as compared to any other hematological malignancies, and then certain case studies to illustrate how NGS is relatively parallel to solid tumors as well in terms of its implication. So genetic testing overall in clinical oncology is profound to have a great impact on hereditary risk assessment. Definitely not only for hematological malignancies per se, but also for solid tumors. Hereditary risk assessment has become one of the major part of doing the screenings and getting the early detection and preventive and being part of preventive oncology, be it solid tumors, breast, ovarian, pancreatic, or be it AMLs or other such diseases. I definitely find a lot of relevance of using genetic testing to estimate the risk of individuals for different cancers. And definitely when we talk about differential diagnosis, so in case of differential diagnosis, there are a lot of mutations and biomarkers that are being defined these days to categorize the tumors, to differentiate between two different overlapping tumor types, be it your in terms of solid tumors or also your hematological tumors, where your genetic aberrations or molecular aberrations define a particular tumor and pave the way for giving a particular kind of treatment. Next thing is prognosis. So prognosis, if you look at prognosis, has in case of prognostification for AMLs, for ALLs, and for all different types of leukemias, the prognostification is definitely done through additional biomarkers that are being mentioned in the guidelines, and the use of these markers is becoming more and more important to take decisions in terms of doing the hematopoietic stem cell transplants or not, and finding out how the patient is going to be. And also, if you look at solid tumors, genes like TP53 or even BRCA1, BRCA2 genes, every other genes, KRAS, all of them have a prognostic role to play. They inform the clinician about the aggressiveness of the disease and how aggressive the treatment should be in terms of when we go on selecting the therapies and deciding on the treatment. Next is therapy selection. So if we look at the therapy selection, this is one of the prime areas where you can find the implication of next gen sequencing per se. Next generation sequencing gives you a benefit of detecting more than one biomarker at a single point of time using a very little amount of DNA or RNA, and you can have a landscape of mutations out of which you can select which mutation is targetable and can give you a better outcome both in hematological and solid malignancies. one of the most important upcoming area is therapy monitoring and surveillance. So the very commonly and the hot topic we come across these days is MRD, which is minimal residual disease monitoring. So be it your solid tumors or hematological malignancies, MRD estimation has become the need of the hour, and there are a lot of new technologies that are coming up in terms of ctDNA or cfDNA monitoring by using the variant allele frequency in the floating DNA, cell-free DNA that is floating in the plasma of the patient. You can monitor the VAF of the VAF or variant allele frequency, that is the percentage of that mutation that is present, that can indicate upon the therapy and also on the chances of relapse. Secondly, if you look at the picture in the hematological malignancies, earlier there were only implications of doing the MRD by flow cytometry, which is an well-established and validated method. But due to its certain limitations, molecular MRD is becoming more and more prevalent and is being explored lately very extensively also, like in terms of you can estimate it, the percentage or the presence of the most important mutations that you are targeting post treatment, and you can find out whether there is disease left or not, because as we look at the proteins that are present on the surface of the cells that act as that are estimated in flow cytometry, we can even look at the mutations or you can say the particular mutations, though that becomes the ID of that particular cancer cell present in the bone marrow, which is causing leukemia. If it is still present, it can be detected up to the rate of 10 raised to power -6. So this is kind of a whole parallel correlation you can find out, illustrate in terms of solid tumors and hematological malignancies. So genetic mutations can be detected with different technologies. We have next generation sequencing to find out for point mutations, that is single point mutation change, and large deletions and duplications can be detected with MLPA and fragment analysis. However, NGS has an ability to detect those, but with certain lower specificity. When we come to translocations, that is the exchange of genetic material between two chromosomal positions, particularly, those can be detected by karyotyping, FISH, RT-PCR, and NGS per se. In case of NGS, you have an option of doing it by RNA sequencing, which relatively helps you to get even the translocation partner, and also has an advantage of finding out any cryptic fusion partner, that is, which is not routinely found partner, like something else with ABL gene instead of BCR, or something else with RARA instead of PML. So those kind of sorry, cryptic translocations can be very well identified using next generation sequencing. So next generation sequencing, if we look at the stepwise flow of it, we have the genomic DNA or RNA. We fragment the genomic DNA or RNA which we get from any kind of sample, be it tissue, bone marrow aspirate, or peripheral blood. We get the fragments of this DNA by enzymatic method, and then we hybridize these fragments with the probes or the targeted sequences which we want to sequence for. Then we go for a washing and pull down so that we get only the DNA which we are targeting for. The captured DNA is then put into a sequencer, and when the data is received, there is mapping, alignment with the human genome sequence, and then we can call the variants using various bioinformatic tools so that we can identify the changes that takes place as compared to the normal human genome sequence. So Next generation sequencing has made significant roads into clinical molecular diagnostic laboratories for routine testing of tumors. In a very short time, this technology has shown a drastic impact on scale, quality, and variety of diagnostic sequencing which we can do, because it has an ability to do high throughput and massively parallel sequencing. You can screen for variety of genomic changes in a multiple samples simultaneously, and this has made this particular platform as a platform of choice, so that clinical testing of solid tumors and hematological malignancies both can be done with high precision and high sensitivity. According to National Survey of Precision Medicine in Cancer Treatment, it indicated that in 75.5% of the oncologists use NGS testing to guide for treatment decisions, which reflects the growing impact and utility of NGS in oncology overall, be it solid tumors or hematological malignancy. So, if we look at the targeted NGS, which is routinely used these days, it is one single test where you can look for all key biomarkers across multiple samples, be it mutations, be it translocations, all can be picked up in a single test. And you can have a very little amount of DNA and RNA, and you can get very great resolution. You can get high discovery power. You can find out new variants, novel variants, and you can find out answers to all possible roadblocks which come in the way of treating diseases like AML. So if you look at AML as per the new ELN 2022 guidelines, there are certain genetic analysis tests that have been indicated in case of AML, and first is cytogenetics, which is a gold standard, which we do by karyotyping. Next is to look for gene mutations that are required to establish a diagnosis and identify therapeutic targets such as FLT3, IDH1, IDH2, MPN1, SEPA, DDX1, 41, TP53, and other such genes. Then next important thing is to look for gene rearrangement by such as PML-RARA. In version 16, AML, ETO, KMT2A rearrangements, BCR, ABL, and other gene fusions if available. Last thing is additional genetic testing, which involves to look for other prognostic markers in AML. And we know that 95% of the AML patients either have a driving and conquering mutations, regardless of the presence of cytogenetic abnormalities.
Ma'am, sorry to interrupt. May we request you to be a little bit in time, ma'am?
Sure, ma'am. Sure. So I will just now move on to the AML diagnostics in terms of various updates that are there using the NGS. So first is genetic predisposition. So there are several updates that are included now for the germline detection of SEPA, TP53, RUNX1, GATA2, all these different variants which are being included as germline predisposition factors for AML patients. Next is to look for the AML classification. We have to categorize them on basis of genetic aberrations, where NGS and other molecular technologies play an important role. So according to ELN 2022 guidelines, AML is classified into for risk categories. A new category of favorable outcome is BZIP, inframe mutated SEPA, and in the adverse categories they have added the mutated ASX1, BCOR, EZ2, RUNX1. So these are the two important changes which have been done in ELN 2022 guidelines. Moving on, how genetic testing helps you to detect new clones in the AML disease journey of a patient. We can do the genetic testing at different steps, and we can identify the mutations with different VAPs, that is MPN1, CKIT, ASXL1, at the time of treatment, then after the consolidation therapy, and after the hematopoietic stem cells. We may find upcoming of different new clones which can help us to establish the same thing. Now coming to MRD, in case of MRD, NGS is mentioned as an exploratory method, and it has a sensitivity of getting up to 10⁻⁴. It is difficult to, in terms of you have to run an error-free NGS, and it has to be very specific as to establish the sensitivity of finding a marker which was detected before the treatment. Otherwise, I will just show you one example where we are using the NGS MRD in AML cases. So now coming to case studies, this is first one is 31-year-old female with AML, found out with FLT3, ITD and IDH2. Post-induction, there was no clinically relevant mutation found. So the testing was done at 2 point of time using NGS itself. In a 32-year-old male, we post BMT, we found a WT1 and NUP98 NST1 fusion, which indicates a poor prognosis combined together. And definitely this is being correlated with a paper which I found out, and by Wang et al. The same kind of combination was found in these case in this particular case, and suggested to have a very poor prognosis. Next is detection of Cbal syndrome in a patient who is undergoing a post-induction, post-MRD BMA for finding out whether the donors also have a Cbal syndrome or not. So the patient was screened for Cbal syndrome and using the buccal swab, and the possible donors were also screened, so that if the Cbal syndrome is present in the donors, they will not be using the donors for the bone marrow transplant for this patient. So germline predisposition testing is also important. This case illustrates that. And next important update is the AML MRD by NGS. So TP53 gene was found in this patient at the start of the treatment at 62.2%, and after the treatment it was found to be at 0.1% per se. This is the lower allelic burden, which was done after almost from December till the 6th of July, the next testing was done. So definitely,
Ma'am, sorry to interrupt. Excellent presentation as always. Last 2 minutes to conclude, please.
yeah, just 2 slides are left. So definitely the key takeaway is that NGS has a very important implication in diagnosis, treatment, response, relapse, and if there is secondary treatment being given, NGS can help you to identify new clones. It can help you to find out late driver mutations, and it can give you an MRD assessment as well. So that is the journey of NGS in hematological malignancy, particularly AML. And I think that it is definitely parallel to solid tumors. So that's all, and I would be happy to answer any questions. Thank you.
So in quick words, ma'am, what's your experience of second NGS at the time of relapse or for the subsequent? What's your experience?
So, sir, if you can, I have just shown a case where the NGS was done at the second relapse, at the time of relapse. So this is a post BMT patient who was relapsed and checked for what are the causes of a relapse in a post BMT patient. So we have definitely we find certain important poor prognostic mutations at the time of relapse in these cases, and it gives a great insight that if this kind of evaluation had been done earlier, before the bone marrow transplant was planned, this could have been helpful in terms of deciding the marrow transplant for the patient and expecting the prognosis.
Thank you.
Yeah. Thank you, sir.
Thank you so much, ma'am.